Welcome to the Prospective Doctor Podcast, brought to you by Med School Coach. Pre-med and medical students alike are encouraged to tune in each week for tips on how to become a strong med school candidate, gain acceptance into the school of your dreams, and succeed on your journey toward residency and becoming a doctor.
Hello, everyone. We have a very special guest today on with me. This is Dr. Kamaria Cayton Vaught here for a very special episode talking about reproductive endocrinology. I want to give Dr. Cayton Vaught a chance to say hello and tell us a little bit about yourself.
Hi, everybody. Thank you so much, Rakita, for having me on. I really appreciate this opportunity. I think what you're doing is great. So a little bit about me. I am currently in my 4th year of fellowship in reproductive endocrinology, infertility, and genetics at Johns Hopkins School of Medicine. So I'm doing a 4-year fellowship when traditionally this is a 3-year fellowship, but I'm doing extra training in genetics. But background, I'm originally from Oklahoma City, Oklahoma, born and raised. I went to medical school at the University of Missouri, Kansas City. It's a 6-year medical program, combined BA/MD. So I did everything in 6 years from high school to graduation. And then I came to Baltimore. I matched for OBGYN residency at the University of Maryland, and that's where I met Rakita at. And University of Maryland, did 4 years OBGYN residency, and I never thought I'd be staying this long in Baltimore, and yet here I am.
Life is funny that way. And
Yes, it
so
is.
Exciting to hear like all of the fun things that you've been doing. Before we talk about where you are now, I'd be interested for you to give a little more information on the 6-year medical school program, because I did a similar pathway, but mine was 8 years. It was just combined. So I want to know, for those students who are thinking about those options, there are some things about like if you're locked into that school, if you choose to do that, or what choices you'll have if you decide to leave the program and go to another medical school.
Right. So, I mean, honestly, the program that I did is, I think if you really know you want to be a physician, then it's definitely a way to go. If you're undecided, if you're not sure, if you want to go find yourself, this is not the program for that. I told my parents when I was 5 that I wanted to deliver babies for a living. They were just like, okay, Kamaria. But I'm like that type of person. I just knew exactly what I wanted to do. And so at the University of Missouri, Kansas City, I think there are a couple of other places in the country to offer a 6-year. I know there's 7 years, and like you said, there's 8 years. So what's different about the University of Missouri, Kansas City program is that the majority of students that are matriculating into the program are the combined BA/MD. Mm-hmm. So, and in other places around the country, you'll have, most people are traditional 4 and 4, and then you may have some that are doing like the specialized, like fast track. However, say if we had a class at 100 at UMKC, 100 of us would be, or 90 of us would be this combined 6A MD program, and then 10 would be traditional that come in after 4 years of undergrad. So it was, that's how it's a little bit different in that regard. And also, so you find out, when you graduate from high school, you go to this program, you essentially do 2 years of just undergraduate coursework. And then after that, your 3rd year, you start doing your traditional med school classes. You don't have to take the MCAT, which is amazing. Like, who wants to take that test, right? So you save money, you don't have to take the test, and which is fabulous. And so you start off really early on by doing your basic science courses, like in that 3rd year of your program. And then after a year of that, your 4th year, you start doing your more traditional clinical rotations. And, the program is a public university. And so they do also have a high emphasis on primary care. Mm-hmm. So, in traditional medical schools, you may only do like a few months here of internal medicine, a couple months of OBGYN, a couple months of surgery, right? When you're doing your clinical rotations. At UMKC, we did like 6 months of internal medicine, inpatient internal medicine. So we did a lot more. And we had like our own continuity clinics from the get-go. So once you start off in the program, you're assigned to a docent, which is a team of students ranging from, your 3rd year up to 6 years, who are preceptored by an attending physician. And you kind of go, that's who you do your inpatient medicine rotations with your group, that group of people. And you're doing all your rotations, internal medicine rotations with that same group and that attending who is a usually internal medicine or family medicine physician. And then, so you kind of grow with them. So you have like guidance from, older students who are about to graduate, and then they kind of like show you the ropes. So it's very nice in that sense. And then you also will start your own continuity clinic at that same time. So you'll be seeing your same patients over that 4-year period, which is really nice, and I think it gives you a good base of knowledge for medicine in general. And it does really foster that drive or that need for primary care physician, because that's who mostly does come out of the school. Not saying you can't specialize, like I'm OBGYN, I'm super specialized REI. So, my best friend who I met in the program, she's like a plastic surgeon who specializes in microvascular surgery at Cedars-Sinai. My husband, who I met in the program, he's maternal fetal medicine and critical care. So it's just not that. I don't think if you are looking at a program that can get you to places you want to be, I think it's still possible to do that. Now, I will say this is that you're studying year round. There's no breaks, so we didn't have a summer off. You may have like a month where you have vacation, but you're kind of going at it, you're grinding. And, everybody else in undergrad is partying and going and doing all these things. And you may not have that luxury because you're doing like your anatomy test that you can study for every, 2 weeks. So I will say this, I did still have a life. I joined a sorority. I was very active in my sorority in undergrad. So I think you could still do the things you want to do. I traveled a month in Europe. So, I think you can kind of tailor it to what you are, but the expectations need to be like, you got to grind it out. It's not easy. There are definitely people who, don't make it through the program. And there's, like you said, there's not a lot of recourse after that. You do have undergraduate credits that you can do, but you don't get your bachelor's degree until like after your 4th year of the program, even though you do most of your undergrad coursework in the 2nd year, the 1st and 2nd year. So I would say this, if you don't know that medicine is what you want to do, then I would not necessarily recommend this program. However, if it's medicine, this is what you want to do, you're very passionate about it, I think it's a great option.
I love that overview, and I really appreciate that because there's so many different kinds of programs like that where people can matriculate from high school or from college or whatever. And it shows that while there are differences in the programs and they may be quite rigorous because of the time constraints, there is a lot that you can get out of it. If you aren't sure about medicine, it may be okay to go through it the traditional way so that you can think more. But not, why not? Like you mentioned, your friends and your husband and you being so specialized, it doesn't put you in a box, but it kind of helps you get to the point that you want to be sooner. So that would be something that I would recommend that the students look into if you're very early in the game listening to us. And for those that listen, I know most of you guys are in college or already in med school, but perhaps share this podcast episode to your younger siblings or friends.
Oh, yeah. And like I said, there are students that come in after doing 4 years of the undergraduate degree. We call them ND only. Right. So they do come in, and I just think that the program itself makes such great clinicians because it's very clinical focused. Like I said, you're doing a lot of clinical work and a lot of hands-on work. And so I think, if that's something that you really want, it's very, very good for that.
That's awesome. Now you mentioned from a very young age that you had an inkling that you wanted to be an OBGYN and you obviously followed through with it. Can you tell us what made you choose that as a specialty?
I'm not sure why at the age of 5 I decided that I wanted to deliver babies, but my family has been a huge inspiration into why I wanted to get into medicine. I'm a first generation, professional degree medical doctor in my family. I'm the first one. And my brother, who is like 5 years older than me, went under a procedure and had a reaction to anesthetic medications when he was 5. I was like 6 months old at the time and suffered an anoxic brain injury from that. And so my family was very much so ingrained in the medical field, dealing with medical care workers, doctors, hospitals, clinics. At a very, very young age, I was exposed to all of this. I lived in a Ronald McDonald House for some time in Texas, so I was just very intrigued and very fascinated about, the people that were, helping my family and taking care of my brother. And I knew at that time that medicine was for me. So when I got a little bit older, I have a very passionate about women's health. In general, I didn't have a sister growing up. I have 2 brothers. And it was like, I don't know, I think I just wanted to have a more in tune, like a sisterhood. I wanted to be like, I did these like debutante things in high school. Like I just really liked women health in general. And so when I was in high school, my aunt actually went through IVF to have my cousin. And that was like the first time I was exposed to that aspect of women's health. And I was like, how cool is that I can make a baby or help a couple have a baby who couldn't have one before? I'm all about smiles and unicorns and rainbows. So I was like, this sounds great. It's like so happy. Now, and it really is amazing because you are in a woman's life when she's in a very vulnerable position. She's scared, she's emotional, she's anxious. I think being that person in the woman's life and being able to, help her out or guide her and, help her make the decisions that's right for her and her family, and to give her that opportunity to have a family. There are many pathways to parenthood and to having a family, but, participating in that, I get extreme pleasure out of.
And it definitely radiates from you. For the listeners out there, some of you may have known if you've listened to previous episodes that I'm a family medicine physician, and family medicine doctors, when they're in residency, have to rotate through different specialties, kind of similar to like when in med school, but with a little more responsibility, of course. Yeah. And Kamaria and I trained at the same hospital. So she was a OBGYN resident a year ahead of me, and just for memories are flooding back to me. I was on the 9th floor quite a lot because I was the black cloud of my residency class. Every time that I was on call, there were about 20 babies being born. So just watching how she interacted with the women kind of helped me model some of my behaviors with patient care. So it's awesome.
Thank you. That's crazy. I felt like I was running with a chicken with a head cut off in residency most of the time. And those little small rooms and triage, like, University of Maryland is a great place. They just got a whole new overhaul of their labor and delivery. But literally, I tell you, it was like a dungeon in there while we were there. It's so small and cramped. Yeah.
And now touching on subspecialization, you're a reproductive endocrinology fellow now. You touched on it a little bit about your early experience with your aunt undergoing IVF. Is that what inspired you to pursue this specialty?
Yeah, and it really did. And I am kind of, all of us are to some degree, right? I feel like very nerdy, geeky. And I loved like also the very sciencey aspect of reproductive endocrinology. So when we're talking about assisted reproductive technologies, we're talking about something that has been developed, initially in the 1980s, late 70s and early 80s, not here for a long time. And so the ability to take an egg and fertilize it with a sperm and to create an embryo and to culture that embryo, to transfer it back into an intended parent is, I just thought that was like so cool, like in general, just the science behind it. And I felt like the intricacies of it also were intriguing to me. And so after residency, my husband was still in fellowship. And so he was like in his last year of fellowship, and I had already graduated. So I had this weird gap year and REI fellowship is pretty competitive, meaning like, there's not that many in the country, probably around 40 to 50 programs at any given time in the country. And we had already done long distance for like 6 years. So I didn't want to do that again. And, I was like, okay, I'll just wait till you finish and then I'll apply for fellowship after that. But in the meantime, I decided to do research at a reproductive sciences lab here at Hopkins. And, that even further fueled like my love of the field, because I was like very hands-on doing a lot of basic science projects, looking at follicular genesis. And it was like, I was like, I love this. I love doing this every day. I can't imagine myself doing something different.
At Med School Coach, we know that getting into medical school is hard. In fact, 60% of pre-meds who apply to a medical school don't even get accepted. And if you want to get accepted into a top medical school, it's even harder. That's why more students than ever are turning to MCAT tutoring by Med School Coach. Our tutors are all 99th percentile scorers, have been through rigorous training, and can help raise your MCAT score by 12 points or more. You need every competitive advantage you can get to get into med school, so why not get one-on-one tutoring from Med School Coach? Our expert team will create a custom program just for you and help you master MCAT content where you need the help most. You'll raise your MCAT score. We guarantee it. Visit us online at medschoolcoach.com and use offer code PODCAST10 to save 10% up to $400 on a Med School Coach MCAT tutoring package. You can achieve your medical school dreams, and Med School Coach can help.
That's awesome. And had you done any research beforehand, like during med school or during residency?
Yeah, so I didn't do really a lot of research at all in medical school. And then in residency, we're required to do a resident research project and present it at the end of our final year before graduation. And but it was like some clinical research that I did, but not a whole lot. So like my prior exposure to having this, postdoctoral research position in this lab was like zero. I had zero bench work experience. I was like, I don't know. I was like, how do I pipette? What do I do to culture these cells? Like, and listen, you think you don't need math anymore until you like get in there and be like, I need to convert all these numbers to something.
Oh,
so I definitely, right? I was like, volume, concentrations. I think I understand. So, I mean, it was like a learning curve, but it was a new skill set that I had to develop, but I really enjoyed it. And I had a lot of support within the lab to help me out. And so, it was like my real first experience was at that time.
That's really cool. Thinking further into your field, why do you think that it's important for women to think about their reproductive health?
Yeah, so, and this is kind of like going to sound a little silly because this is what I tell my patients, honestly. So as women, right, we are born with all the eggs we're ever going to have. We're not like men. Men generate sperm every day. As women, we have about 1 million eggs right after birth or so. And then by the time we get to menopause, we only have 1,000 eggs left. And that is around the age of 51 or so, average age of menopause in the US. And as we age, we just have a decline in our egg supply. Even though once we reach puberty and when we start to ovulate, you get a menstrual cycle, you get a period, you typically ovulate 1 egg a cycle. Some women can do more than one, but let's keep it simple. We ovulate 1 egg a cycle. Even though we only ovulate 1 egg, we lose a whole bunch of eggs that are not recruited during that process. And so when we start to see a more rapid decline in ovarian reserve or egg supply is around the age of 37 or so. So you see like this gradual decrease, and then boom, at 37, you have a more sharp decrease in your egg number. Now, humans are very inefficient when it comes to like actually getting pregnant. You think it's not as easy as a lot of people think. Like when you're in your peak, your prime fertility in your mid 20s, you only on average have about a 25% chance of getting pregnant each month. And that's if everything you do is correct. You have intercourse at the right time in the month, you're ovulating, all the stars align, then that's a 25% chance of conception happening. And around in your mid 30s or so, it kind of goes down to around less than 15 to 20%. But like when you're 40 and your late 30s, you're looking at 5 to 10% chance. So not only are we, losing our egg numbers, but we are also, the egg quality goes down. So and this is getting kind of like sciencey, but you guys are students, so hopefully this will ring a bell to you. Our eggs are arrested in meiosis until, like at puberty, they're arrested in meiosis until ovulation occurs, and then they go through meiosis 2, and this with fertilization. Then you have extrusion of your first polar body at ovulation, and if you have fertilization, you have extrusion of your second polar body, right? So all that DNA is just in there, and the older your eggs get, the less stable that DNA is, and the more common it is to have errors in meiosis. That can lead to abnormal genetics in the egg, and so that will translate into abnormal genetics in a fertilized egg, which is an embryo. So the most common ones that we see are your aneuploidies. So you can have the like trisomies, so trisomy 21. You can have loss of chromosomes. You can have a whole host of different genetic issues, and that typically correlates with age. And that's why we say advanced maternal age is around 35, because at 35 they kind of start seeing that increased risk of having a child affected with a genetic chromosomal difference compared to the baseline population. And so that's why you're actually at increased risk for miscarriage as you get older too, because most miscarriage, around 50% of the time, are due to abnormal chromosome numbers. So you can imagine 35 hit, 37, we're looking at, you got everything stacked against us as women. You have decreasing eggs. You have eggs that are bad quality or decreasing quality. You have higher chances of having miscarriages. And so, those three things stacked against us makes it more difficult. So now with today's technology and the ability to freezing our eggs at a given time point to preserve their quality, if I could use eggs, when I was 34, when I'm 40, those eggs are going to be way better, and I have a higher chance of having a live birth or a child. So I really do, as our technology has evolved and developed, so egg freezing is relatively new. The technology is now, we use vitrification of the oocytes as this type of cryopreservation. And it was considered experimental for a while, but no longer is the case. And so we are seeing more and more women come in who want to do what we call planned oocyte cryopreservation, meaning, they may not have found Mr. Right, or they may be too busy in their lives, going through their careers. We also see the increasing, the average age for women starting a family increases, over the years, the time that she gets married increases. So all these things, like women are deferring childbearing. And so if you can defer childbearing to get your goals in your career established, but still have that insurance that, maybe I don't want to have a child now, but I want the best possibility to have a child when I get ready to do so, I think egg freezing is a great option.
That's awesome. So what advice, and I think you kind of mentioned it in your talk, but like what advice would you give people in all areas of medicine training in their journey, like pre-med, med students, residents, attendings, about reproductive planning, even if they're not planning to have kids at this point in their life?
I guess the first thing that I would say is just make yourself knowledgeable about the process. And, as scientists, as physicians, we're very familiar, more so than, our other colleagues or, our family or our friends. So we have that benefit of having that that somewhat of an education, but I encourage everyone to read a little bit more about it, to get a little bit more familiar with it. This is something, if it's something that's really important to you, like, you know, and even if you're not sure, I think it's important to, you know, read up on it and see if this is something that would be something you would consider doing. Because what don't want to happen is, you know, we finish all our training, you know, look, I'm a PGY8. That's crazy, right? I graduated medical school in 2011. I'm like, it's like been a long time of post medical school training that has gone into this. And so, you know, I'm very happy where I am in my life, and I'm very glad. But, you know, people who are, you know, maybe started off later in life than me, I didn't do an accelerated program like me, so they're not, you know, young. I think it's so important just to start trying to think about it. Just like, you know, Google. I mean, Google is good for some things, but, or, you know, go to your, you know, the ASRM, American Society of Reproductive Medicine website has a lot of good information. Resolve.org, which is our advocacy organization for reproductive medicine, also has a lot of good information about planned oocyte cryopreservation. Men don't have to worry about it as much because, like I said, there really is not a lot. Paternal aging is not become really relevant until, you know, we're talking about a male in their 50s. So it's not, typically it's not something that we do see, but, you know, for, you know, our women colleagues and our women friends, I think this is something that you can just think about. And a lot of that has to do with what is the process? And I don't know if that was something you're going to ask me, but I could talk about it if you want.
Absolutely. We're here to listen to it all. Maybe a little bit about the process. And if someone decides that this is something that they want to pursue, would they be able to have the time to do it during training?
Yeah. So one thing I may not have, you know, talked about a lot before this is that there are many different pathways to parenthood. Having a genetic biologic child is one of them, but there are others that are important too. Adoption is, you know, something that is very viable if that's something that you would love to do. There is not, you know, single moms by choice. So if you want to, you know, just get pregnant using a donor sperm, that's totally fine too. Like if you decide that you're in that point in your life, maybe you don't have your partner, but you are ready to have a child, that's something that can be done as well. And then there is the option of freezing the eggs. So typically it's the same exact process as going through IVF. There's no difference until the very end. So what that entails generally is you take injectable medications. They're called gonadotropins. So they have follicle stimulating hormone, or FSH, and LH, luteinizing hormone. You inject yourself for 10 to 14 days. And what those medications do is stimulate your ovaries to produce multiple follicles. And instead of one dominant follicle that we typically produce every month, we want to cause a controlled stimulation or controlled ovarian stimulation and have multiple follicles being produced. And each of those follicles potentially has an egg in it. And so what happens is you'll come in for a baseline ultrasound so we can take a look at your ovaries. We can count your, what we call an antral follicle count, to see how many follicles kind of we're starting off with. And then you'll take the medications for like around 4 days. They'll come back in. We'll see how you're responding to medication by measuring the follicles to see if they've grown in size. And then you'll come back in, you know, a few days after that. And towards the end of the stimulation, you may be coming in daily to assess the size of the follicle. We measure them, and each center has different protocols, but you know, once they get a certain size, or there's so many greater than a certain size, then we determine that they're ready to be triggered for ovulation. You'll take a trigger medication, and then typically your egg retrieval is about 36 hours later. And what that entails is you have an ultrasound procedure, and in most centers you're put to sleep, like a light sedation. You're not intubated per se, unless there's risk factors or anesthesiologist thinks you need to be. And we have a little needle on the end of our vaginal ultrasound probe, and we're able to go in through the vagina and put the needle into the ovary and then aspirate the follicles into a little suction tubing into a little collection tube. Then we send it off to our embryologist, and the embryologist says, yes, there's an egg there. And then at that point, your eggs are frozen. All the mature eggs are frozen. So those are the ones that went through meiosis too after they were stimulated. And so they're called M2 eggs or mature eggs. Those are then frozen to be used later on down the road when you find a partner, or if you want to use donor sperm when you decide to have a child to fertilize. Now, if you're going through regular IVF, you create embryos. So the only difference is then we fertilize the eggs at that time and then create embryos. And then some women, like especially, and this is like a whole nother topic to get into, but some women choose to do egg freezing and embryo creation. So they want like a donor sperm and they want to make some embryos, because typically, even though we're really good at freezing eggs are the largest cell in our body and have a lot of water content. So when we go to thaw them, when we want to fertilize them, not all of them make it. Most centers have around an 85% to 90% survival rate after thaw. So if you can imagine, if we collect 10 eggs, we may have 8 that make it. And out of those 8, maybe, and this is all age dependent, maybe 4 or 5 fertilize. And then maybe about 3 or 4 of those grow on to be, full on blastocyst, 5-day-old embryos that are suitable for a transfer. So the retrition rate of eggs is not 1-to-1. And I want to make, stress and make that an important point. But embryos, typically, if you create embryos, right, after you collect them, they typically do better with the freezing as well. And most centers have like a 99% like survival rate of embryos. So it's a very personal decision, and it's something that I encourage everyone to, if you have questions at all, just go in for a consultation with a reproductive endocrinologist. What are your options? How much does it cost? Is this something that you could feasibly do? And for our center and most centers that I know of, we do all ultrasound monitoring very early in the morning. So like at 7 a.m., typically you're out like in the next 10 minutes and you go about your day. So I've had med students go through this. We've had residents go through this. We've had attending physicians go through this. And we're very flexible. Most centers are, and we do everything very early, 7 days a week. Like we only close for Christmas and New Year's. We're open. So we're open most holidays. So it's something I think is very reasonable and feasible to do if that's something that you want to pursue. But I do really encourage, just kind of like go out and see what your options are. Have the initial consultation.
At Med School Coach, we know that matching into the specialty of your choice and the residency program of your dreams has a dramatic impact on your career as a physician. And your USMLE score is the most important acceptance factor of all. That's why more students than ever are turning to Med School Coach for USMLE tutoring. Our tutors are all 260 plus scorers and have been through rigorous training. Plus, the average student who uses Med School Coach tutoring raises their score by 23 to 55 points. There is an enormous amount of material you need to know for Step 1 and Step 2, and Med School Coach can help you be smart about how to study. We'll create a custom program just for you. Then, we'll help you master USMLE concepts where you need help most. You'll raise your USMLE score. We guarantee it. Visit us online at medschoolcoach.com and use offer code PODCAST10 to save 10% up to $400 on a Med School Coach USMLE tutoring package. You can achieve your medical school dreams, and Med School Coach can help.
I really appreciate that overview, and I love that you stress that someone has to figure out what's right for them, and they may not even know that at this point. So if you have any inkling, consult a reproductive endocrinologist just for a consult, and that some people may want a genetic child, but adoption is definitely an option, and then some other options. So it may be okay to explore those options with you, as well as making the time. It's a lot of centers, like you said, are flexible and open and available. So if you think that is something you want to pursue, look into it.
Yeah, I mean, it doesn't hurt seeing just for that initial consultation. A lot of times, but the number one question I typically get is, so what age is the ideal age to freeze my egg? Mm-hmm. And studies have shown the most cost benefit time, is around the age of 37. So I typically like to do it a little bit earlier if that's something that you want to pursue or know you want to pursue or thinking about pursuing. Typically, again, because we're probably going to have better success rate or better outcomes in the woman that's younger. But 37 is that point where they say, it's cost effective to do egg freezing, because if you try to get pregnant on your own, and the one study that this is coming from is a study that looked at women, and we didn't have follow-up yet because women hadn't come back yet to use their eggs. So they used an arbitrary number, 5 years or 7 years. So on average, it's probably 7 years a woman will come back to use her eggs. And they also looked at if that woman was going to be married at the time or not married at the time. But they found is that at 37, it's most cost effective. If you're really using your eggs 7 years from now, at 43, your chances of having a live birth on your own are very small. Versus, if you collect eggs at the age of 37, you're looking at probably, if you get 10 to 15 eggs, you're looking at about a 50 to 60% chance of having a live birth. So, I think, and that's if everything else looks good. Absolutely. So, again, it's a very personal decision, and do what's right for you. And I just encourage you just to seek that initial consultation, get, a very reserved testing, see kind of where you're at in the spectrum. Like, if this is something you need to be pursuing now because maybe your egg supply is a lot lower than you thought it was, or something that maybe you can defer a little bit.
Thank you for that insight. Now, you've shared so many pearls of wisdom with us. My final question for you is, what is one of the best lessons that you've learned that sticks out to you about your medical training?
Wow. So I think, and I don't even know if this happened in medical training per se, but it's my approach that I take generally every day when I wake up and then before I go to bed. And it's something that my father taught me. And he said to me, Kamaria, are you a good doctor today? Did you treat your patients with compassion, with kindness? Did you listen to them? Did you do your best by them? And I think sometimes when we're busy in the hustle and bustle of learning all these charts, learning all these, all the anatomy, learning all these techniques that we have to do, that we get caught up. And at the end of the day, it really is about the patient and your interaction with them and how you make them feel. And so I really try to bring that to my everyday medical practice, and even when I'm learning. And I think it's something that, is a good exercise to do when you are stressed out, when you're running low on time, when you have all these other 9, 50, 11 things to do. All right, at the end of the day, are you a good doctor? Did you treat your patient how you wanted to be treated? And I know that's the golden rule, but, yes. I've been on the other end of the stick, and maybe we all have, where we did not have that interaction that was pleasing to us and maybe hurt us. So my advice to you guys as student doctors and as future student doctors and as my future colleagues is, at the end of the day, were you a good doctor?
I couldn't have said it better myself. Thank you so much for joining us today, Kamaria. And
no problem.
I guess we'll just say goodbye.
All right, bye. Thank you so much, Orquídea, for having me. This was great.
Thank you. Bye, guys. See you next week.
Each episode of the Prospective Doctor podcast is brought to you by Med School Coach. To access articles, videos, webinars, and free tools to help you succeed on your journey toward medical school and beyond, visit our website, prospectivedoctor.com. We hope you tune in again next time.